I'm Bron Tuller, and this is Psych Matter. In part one of our discussion related to suicide, we covered statistics regarding suicide. We covered some terminology. We covered why someone may attempt or commit suicide. And then lastly, how to identify someone who is suffering from significant depression or suicidal ideation. In part two of our discussion, we're going to be talking about the assessment of someone who is suicidal. By the end of this discussion, my hope is that we'll have a better understanding of how to take action once somebody has been identified as struggling with suicidal ideation. So we're just going to jump right into it. We last covered the identification of someone who's suicidal. You can't look at somebody and say that person may or may not commit suicide. You have to have a good close relationship with them so that they confide in you and ask for help. Now, what we're going to cover in this next portion is the assessment. And what that is it's putting the identification into action. Identification is knowledge-based. It's you cognitively know that, okay, this person is suicidal. Assessment is when you start to pass judgment. People get freaked out about the term judgment, but in reality, that is what's happening because you have to judge the situation as being truly dangerous, maybe dangerous, or not dangerous. And part of that, you're going to want to rely on psychiatric professionals, but it's also important that you're able to do that in your home, with your friends, with family, whenever you need to. So, the assessment. The first thing that you have to assess once somebody has said, I'm suicidal or I'm incredibly depressed is, are they having suicidal ideation? Specifically, is it passive or active? And if you remember in part one, we talked about the difference between the two, but I want to go a little bit more into depth on what those terms actually mean and how we can utilize those when we're assessing somebody. So we'll start with passive suicidal ideation. Just as a review, passive suicidal ideation means that somebody is thinking about suicide, but they're not taking action towards taking their own life. Some traits of passive suicidal ideation include wishing. I would say the most common one is the person who, lays down in bed at night and has that wish, I hope I don't wake up. It's not that they're doing anything to not wake up, it's just they're wishing. I wish that something would happen. I wouldn't mind if I got hit crossing the road or while I was driving. They're wishing for it. A lot of times passive suicidal ideation is also intrusive in nature. So what intrusive means is that it's distressing and unwanted. So an intrusive thought means that out of the blue, unbidden, a thought pops into the person's head. And it's usually something that is ego dystonic. And that's a fancy term for meaning that it goes in opposition to what their personal feelings or beliefs are. So someone who's extremely depressed but not necessarily suicidal might have these blasts of thoughts where suddenly they get a flash of something happening to them or them doing something to themselves. And even though they would never actually do that, it's a suicidal thought. So you have to evaluate that as well. Intrusive thoughts are actually a good sign with suicidal thinking because it's a representation of the severity of their depression, but it's not a representation of the likelihood of them committing suicide necessarily. Like I said, the thought in passive suicidal ideation tends to be distressing to the individual. I'll have patients who come into my office and say, I'm so depressed, and when I ask them, are you thinking about suicide in any way, shape, or form? And I can visually see that they're distressed by their response being, yeah, but I don't want that. I would never do that. Why is that thought happening? And again, it's an indicator of the severity of their depression. It's a symptom of depression. And so we treat the depression and the passive SI or suicidal ideation goes away. Oftentimes passive suicidal ideation is redirectable. So the person is able to put it out of their minds once they have the thought. It's not something that they welcome or usher in or elaborate on usually. So they're able to push it aside and keep on keeping on. Generally speaking, passive SI does not have a plan associated with it. So, you know, when you're asking somebody who is suicidal, have you thought of how you might do it? A lot of times people with passive SI will say, no, I don't have a plan or anything. I'm thinking about dying. I'm thinking about, what if something happened to me? And a lot of times, the last sort of trait of passive SI is a lot of times there's no altered behavior in the individual. Or maybe a better way to put it would be that the passive SI does not influence the person's behavior. So they'll have, the thought, or if they purposely think about it sometimes, it's not something that changes how they're functioning, what they're doing. It's passive in nature. Like I said, passive suicidal ideation is often a symptom of depression, so it's not something to necessarily panic about. It's something that you definitely need to know, and you definitely need to be asking these questions. But usually, if somebody has passive SI, there's time for intervention, but you need to proceed with caution. You need to keep an eye on it because passive SI can roll over into active SI. So it's definitely a warning sign, but generally speaking, when I have a patient who has passive suicidal ideation, I do not send them to the hospital. I get them help, and usually I'm the help. So we make medication changes, we'll pursue more in-depth therapy, we might move up our appointment times. Now that's me as a psych professional. If you're a loved one or a friend of somebody who you find out, yeah, I'm thinking about these things, you're going to want to get them hooked up with a psych professional, but you may not and probably should not, call 911 and pull the fire alarm. Again, nothing is straightforward. So you have to feel good about what you're doing, and in the worst case scenario, you always err on the side of caution. So with passive suicidal ideation, typically you treat, watch, and wait. So passive suicidal ideation. Its counterpart, active suicidal ideation. Again, we talked about this in part 1, but let's fill in the blanks a little bit and elaborate some. So active suicidal ideation is obviously the opposite of passive SI. It means that the person is actively pursuing the taking of their own life. There's a plan, they've got the materials, they're saying their goodbyes, getting affairs in order. So the active SI is significantly more concerning than passive SI, again, generally speaking. Now there are two subtypes of active suicidal ideation. One is controlled and the other is uncontrolled. With the controlled suicidal ideation, the person has a range of choices, but they opt for suicide. They have treatment, but they're choosing not to go that route. They have family and friends, but they're choosing not to engage in that direction. They are tired and they're worn out and they're ready to call it quits, and so they actively pursue suicide. The uncontrolled suicidal ideation is when the person is actively pursuing suicide, but it's because they don't see any other way. They've tried medications, they've tried talking it out, they've tried, X, Y, and Z, and nothing has worked, and therefore the only solution that they can see is the taking of their own life. Both of these, again, are subtypes of active suicidal ideation, so this is like red alert, definitely. But the controlled subtype is by far the most dangerous between the two, because the controlled type, it's more of a logical process, and they've made a decision and they're working towards that, and so it usually requires very rapid, fairly aggressive intervention. The uncontrolled is, you can sort of think of it like a stepping stone in between passive SI and active SI. And so a lot of times with the right conversation, with the right support, you can de-escalate the uncontrolled subtype into more of a passive SI. But again, if it's active suicidal ideation, you need to do whatever you need to do to keep the person safe, which we'll talk about in a moment. Active suicidal ideation, in essence, means that the individual is an imminent threat or danger to themselves. I would say the two biggest red flags is if there's a timeline and if there are what I call closing actions. So a lot of people have a plan for suicide. It's something that, depression is not something that typically is a thunderclap event. It's something that builds over time and the person becomes overwhelmed and worn down. And so there's lots of time for the person to think, which can be a good or bad thing. So lots of people have a plan, and that's definitely a bad sign. But if there's a timeline, so if the person says, if I'm talking with a patient and they say, yeah, I'm thinking about committing suicide and I have a plan to shoot myself. Definitely, I'm worried, I'm concerned, I need to take action. But if they have a timeline as well, if they say, yeah, I'm waiting for the anniversary of my dad's passing, or I'm waiting for this weekend, I think I'm going to do it this weekend. That's a big red flag, and that's when you want to definitely take action. And same with closing actions. If the person starts giving things away, if they are, getting their will and their assets and disseminating these things, again, that is a red flag that things are, they're at the brink, and so you need to make sure that the individual is safe. If there's active suicidal ideation, intervention is required. So don't make the mistake of when somebody says, yeah, I'm actively thinking about suicide, I have gone out and gotten the items, or I have immediate access to what I need to commit suicide, I have a timeline, I'm saying my goodbyes. Do not make the mistake of being like, well, okay, I guess I'll wait a little bit because I don't want to get the person in trouble. No, you need to take action right then and there. Make whatever phone calls need to be made to get the person safe and keep them safe. When I have a patient who I have identified as being actively suicidal, the second that in my brain I have identified them as being actively suicidal, and that's my assessment, they no longer are free to leave my office. Of course, I don't say that out loud, but what I'm saying is that I can't allow that person to leave in good conscience because they have told me that they are an imminent threat to themselves. So don't make the mistake of waiting once somebody has admitted to active suicidal intent. Okay, so we have talked about the identification, we've talked about the assessment, primarily being, is the person passively suicidal or actively suicidal? And then if you want to get into the nitty-gritty, is it a controlled active suicidal ideation or is it uncontrolled active suicidal ideation? But then what? So you have the information you need, but now what do I do? This is one of the questions I get asked all the time, is, okay, so I know that my boyfriend is depressed. I suspect that he's thinking about suicide, but what do I do about it? And this is where things get uncomfortable. So again, if it's passive suicidal ideation, you have to use your best judgment. But typically, you pursue treatment, you watch the individual closely, and you wait. Because again, that passive SI can roll over into active SI. Of course, you want to give the person TLC, tender loving care, love, support, making sure that they know that they're not alone, that they're not hopeless, they're not helpless, and that they're in control. If somebody has access to potential tools that could be fatal, so stuff like firearm, if somebody's like on opiates or other controlled substances that could be fatal, you want to make sure that those are locked away or removed, and have that conversation with the individual. And that's for passive. So you're protecting things. If active, though, that's when you need to take action. So what does that mean? The first thing I want to talk about when going into this is what is danger? So danger is defined as the exposure or liability to injury, pain, or loss. When somebody has admitted to being actively suicidal, they have become dangerous. If you were to talk with somebody and they were to say, yeah, I'm thinking about killing my friend, you probably wouldn't hesitate too much about saying, I need to call the police, or I need to get this person like in safe hands right now. But for some reason, when someone says, I'm thinking about killing myself, people tend to hesitate a little bit. It's exactly the same. I have this conversation with my patients, especially where somebody is using suicidal threats as a means of manipulation. The person who is threatening suicide is doing the same thing as threatening somebody else, saying, I'm going to kill this person. Because it's exactly the same, it's the taking of a life. So the same way that you wouldn't hesitate to protect somebody else who's been threatened with their life, you need to take that as seriously with the person who is threatening themselves. They are a danger, and so you need to treat them as such. Now, there are few more dangerous things on planet Earth than a life form which has been backed into a corner. Weird, strange things happen when people realize, I may have to go to the hospital, or I may have the police called on me. So when you start to manage the actively suicidal patient, you need to proceed with caution and with care, because strange things can happen. A lot of people will argue that suicide is not done in the typical or logical frame of mind for the individual, and I tend to agree. The person who commits suicide usually is not themselves. They're in an altered state, whether that means that they're in the depths of a depressive episode, or whether they're under the influence of a substance, or whether it's in the immediate aftermath of a huge argument. But the person is usually not at their baseline. Because of that, you need to be aware that all bets are off. The person may not act like themselves when you start to talk about managing somebody who's actively suicidal. So we've said that somebody is suicidal. We've said if someone is suicidal that they are essentially dangerous. Of course, you also have to understand that somebody who's out of control is also dangerous. So if somebody is manic, meaning that they're in an accelerated state of being, elevated thinking, impulsive decision making, trying drugs, spending tons of money, just not acting themselves, you need to understand that that person who's out of control has the potential to do something out of control, specifically in this discussion, commit suicide. So if somebody's out of control, they are also dangerous and they also need to be managed the same way. If they're in the midst of a psychotic episode, seeing or hearing things or any other sensory experience, or if they're, just not acting like themselves, you need to consider that individual potentially dangerous. And again, danger means that there is an exposure or liability to injury, pain, harm, or loss. So if somebody's out of control, it is a safe assumption to say that suicide is a potential. So now, when we're talking about managing somebody who's suicidal, sometimes both professionals and lay people get hung up on the why. So they go through the identification process. For medical people, that means screening. For non-professionals, it's talking, and the person confides in you that yes, I'm depressed and thinking about suicide. So they go through the identification, they go through the assessment. Is it passive? Is it active? Okay, it's active. And then sometimes people get hung up on why. Well, why are you feeling this way? Why are you thinking about committing suicide? Do not waste your time with that. And I know that I'm coming across a little bit forceful with that, but there is no point to investigating the why in that moment. Because again, once somebody has admitted to being actively suicidal, they are an active threat or danger to themselves. And it doesn't matter what the reason is. The only thing that matters is that you need to get that person safe and sound. Now, sometimes asking why can help build further rapport, which again is really important. Yes, we talked about that for the identification, but it's even more important for the management. So I'm not saying that you shouldn't ask why, but don't get hung up on it because you need to take action at this point. Of course, for passive suicidality, the why may be important because we already said that somebody who has passive suicidal ideation, there's time for treatment and intervention. So it's a preventative, usually, situation. So it's actually really important in somebody with passive SI to say, why? Why are you feeling this way? Well, because I'm in an abusive relationship. Because then you can step in and you can make changes. And again, de-escalate the person out of suicidal thinking. That is it for part 2. I hope that some of that information is helpful. There is a part 3, but part 3 is, tune in next time and you'll see what part 3 is on our discussion on suicide.